Hello. 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 Nitya. नहीं खोला तो
Full screen.
This I have already done it. Am I audible?
मैडम इसको full screen करिए.
Am I audible?
Can you hear me, madam?
Full screen कर दूं? Yeah. You are able to hear me?
Hello, madam. Good evening.
Good evening. You are able to hear me?
Good evening, Shambhavi ma'am. Good evening, Sashmita ma'am.
Good evening, Mr. Nitya. Good evening, Dr. Sashmita.
Good evening, Dr. Sambhavi. Subham, this I will allow.
Just 1 minute. Can you hear me?
Yeah. I have already shared the screen. I think it's okay.
Yes, we can see Dr. Sashmita.
Hello.
Yeah, we can see the screen. That's fine.
Okay. So we will go like this only. I will not minimize now.
You can just shift the slides
No.
and see whether it's moving or
Yeah.
not.
Good evening, Shambhavi ma'am. Can you hear me?
Yeah, I can hear you, Mr. Nitya.
Sashmita ma'am, good evening.
Yes. Good evening.
Yeah, it's fine. Perfectly all
Yes, we
right.
can see Dr. Sashmita. Yeah, I can see the screen.
Yeah.
That's fine.
So, ma'am, we are also live on YouTube.
So we will go like this only. I will not minimize now.
You can do it minimize also. Good evening, Shambhavi ma'am. Can you hear me?
Yeah, I can hear you, Mr. Nitya.
Yeah, we are live on YouTube also, so the repetition is coming. 1 minute. Just let me share you the basically link of YouTube also, that if anyone wants to see, they can see it in YouTube. I have shared in the group. Shashmita ma'am.
Only 18. Yes. Tell
I am
me.
having basically your
Tell
मैं
me.
बोल दूं कि मेरा introductory slides है आपका CB. So for a second,
Okay.
you have to stop sharing. Once I introduce yourself, then I will be handing over to you. Yeah.
Okay.
I am muting everyone. Still 8 minutes are there with us, so we'll be waiting till 8 o'clock. I have shared the YouTube link. Anyone wants to see, they can check it in YouTube also. Respected doctors will start at 8 o'clock. So please wait. We are having 4 minutes left.
Hello. Hello.
Good evening, ma'am. 8 o'clock.
Yes.
Yeah.
I think we must start now. It is already 8 o'clock. It is better we should start.
Sure, ma'am. So, good evening, viewers. Just 1 minute. My slide is visible, ma'am.
Yes,
Madam,
Yeah.
So, good evening, respected doctors. Welcome you all on this interactive session on autism spectrum disorder. Today, we have got very eminent speaker from 2 different parts of this country there. And with us today, we have got this eminent pediatric neurologist, Dr. Shashmita Devi Agarwal. Dr. Shashmita Devi Agarwal is a professor pediatrics, consultant pediatrics neurologist. She is associated with High Tech Medical College and Hospital Bhubaneswar. And Dr. Shashmita Devi is associated with National Advisory Board member and president of Academic of Pediatric Neurology. Welcome, madam. BioBliss express gratitude to get such an eminent speaker in this forum. So welcome, ma'am. We have also got with us Dr. Shambhavi Sheth. Dr. Shambhavi Sheth is an eminent developmental pediatrician, and she is the senior consultant associated with Max Hospital, Saket and Gurgaon. Madam is director, Bright Beginning Child Development Center. Welcome, ma'am. So today this session is, basically this month is being considered as an autism month to rather increase awareness about the autism spectrum disorder. So we would invite today's first speaker, Dr. Shashmita Devi Agarwal, to put her presentation and enlighten us about this autism spectrum disorder. So whatever the questions and queries are there, you may put it in the chat box, or at the end of this meeting, you can also ask it directly. So welcome, ma'am. You can start your presentation. Shashmita, ma'am, over to you.
Yeah. I am sharing my screen.
Yeah, please.
Is it visible?
It is coming. Yeah.
Are you able to see?
Perfect, ma'am. Perfect.
It's okay.
Okay.
Good evening. Thank you, Mr. Nitya Gopal, for the kind introduction. And I'm really thankful to the entire team of BioBliss, Mr. Satyanarayan, Mr. Jyoti Kumar, Mr. Nitya Gopal for having me here today. And many thanks to Dr. Shambhavi for help and cooperation for this webinar. As you know, this is the month of autism awareness. When I was doing the post-graduation, I have hardly heard about autism spectrum disorder. But today, the incidence is 1 in 59. 1 in 9 children suffering from autism spectrum disorder. So as you know, this is the month of autism awareness. We must create the awareness regarding this disease. It is this is not a disease, this is a disorder. The incidence has increased not due to any outbreak, this is due to the awareness, okay? Awareness among the parents, among the doctors, and in the society. Now we should create more awareness regarding the early diagnosis and early intervention. So the topic for me is, what are the challenges in the diagnosis of autism spectrum disorder? The focus will be what is autism spectrum disorder? What are the etiology of autism spectrum disorder, so that we can plan for our investigation. All investigations are not necessary to confirm the diagnosis of autism. So first we'll see the etiology. Accordingly, we can plan for the investigations. How and when to suspect autism spectrum disorder, and how to diagnose autism spectrum disorder, and what are the challenges we are facing to diagnose this condition. As you know, it has been described since early 19 as a neuropsychological condition. Autism has come from a Greek word autos, means self. The child has locked himself within himself by himself. So he is not to understand about the surrounding. According to DSM-V criteria, it is defined as a lifelong neurodevelopmental disorder with age of onset below 3 years. characterized by decrease in the social communication and restricted and repetitive behavior. Okay, so this decrease in the social and communication skill along with the restricted and repetitive behavior, it must cause some kind of clinical impairment in the child. So if the child with decreased social and communication can go to the school, can maintain everything, can go to the shop, can buy something, then it may not be a case of true autism spectrum disorder. Okay. You see, in autism, no two children are alike. So we can say it is always unique, totally interesting, and sometimes they look very mysterious because of their restricted and repetitive behavior. Autism, everyone is unique with their own abilities, talents, challenges, and the symptoms. So we as the pediatrician or pediatric neurologist or developmental pediatrician, we have to find out what the talent the child is having and what ability or talent the child is having and what challenge he is facing to show the talent. So if we can identify these two conditions and start the intervention early, the prognosis or outcome will be definitely different. You can see here, he's putting this numbers very nicely. So this is a pattern of development, or you can say this is behavior. This may not be a good one. We have to find out talent or what ability the child is having and what challenge he is facing to show this talent. If we can identify and start the early intervention, definitely the prognosis or outcome will be very good. So before going to the autism, we must understand what are the autism mimics, what are the conditions which looks like autism. First is social and communication disorder, anxiety disorder or selective mutism, cognitive impairment, hearing impairment, visual impairment, normal behavior variation. Okay, so particularly conditions about disorder, selective mutism or normal behavior, if the parents are telling the child is quite normal in the house and he is doing everything normally in the home, as soon as he's coming out, the behavior is quite changing, is becoming abnormal. Okay, he is having very poor eye contact, he is not speaking anything. In this particular condition, you ask the parents to provide the video in the home, in the family environment, in the home, how the child is behaving in the home. So if the eye contact is normal in the familiar environment or in the home, and he is following the command, then definitely it is not a case of autism spectrum disorder. If there is delay in the language, but the child is using the gesture, it may be due to hearing impairment. If there is a language is normal or speech is normal, but there is delay or inappropriate use of the gesture, then we should think about the visual impairment. Okay, so these are the conditions which mimics like autism. Now we will see some cases. You can put your answer in the chat box. You can see here, this is a child who has for verbal communication. Also, there is for social interaction. So is this condition, whether it is autism spectrum disorder or any of the mimicking condition, you can write down your answer in the chat. There is poor verbal communication, there is poor non-verbal communication, and there is poor social interaction. So whether it is autism mimics, it is a autism spectrum disorder. You can write down your answer in the chat box, we will see later on, okay? So this is a social and communication disorder. Why it is a social and communication disorder? Because there is no any restricted repetitive behavior, okay? So if along with all these features, there is a restricted and repetitive behavior is present, then we can say it is an autism spectrum disorder. This is a 3-year-old female child. Also, you can write down your answer in the box. Came to us with delayed language. She is using the gesture. The behavior is very aggressive, but is very not with all kids of the same age. What is your diagnosis? Whether it is autism spectrum disorder or any mimicking condition, you can write down your answer in the chat box. there is delay in the language, there is hyperactivity, she is not playing with the other kids, but she is using the gesture, okay? So this is not a case, autism spectrum disorder, this is due to hearing impairment. So you can see here, autism is not a disease, this is a disorder due to developmental disconnection. This is a developmental disconnection. So if we can identify this condition during the early part of the life, that is below 3 years or at least below 5 years, when the connectivity among the neuron is still going on, and we can start the intervention early during that period, then definitely we can change the disconnection and we can change the prognosis outcome of this disorder. Okay. So what are the advantages of early diagnosis? The advantage is there will be improvement of cognition. We reduce the secondary problem and abnormal behavior. And all this thing is possible due to the neuroplasticity. As I've already told, the newborn baby will have millions of neurons at birth, okay? But they are not connected with each other. The connectivity occurs during the early part of the life, that is below 2 years, or it may continue up to the age of 4 to 5 years, okay? So if we can start, we can diagnose below 3 years, below 2 to 3 years, and start the intervention early, we can change this connectivity, we can change this disconnection, we can modify this disconnection, and definitely the prognosis or the outcome of these children will be different. So before DSM-V autism many times, but now we are telling it is a spectrum of disorder. Extreme end of IQ is possible. There can be low IQ, which was previously called as classical autism, and high IQ autism, but now it is only autism spectrum disorder. You can see there is a famous personality with autism spectrum disorder. So no need to be very much worried. Our focus should be early diagnosis and early intervention. Now coming to the etiology. What are the etiology of autism spectrum disorder? Basically, we can divide autism into two groups. That is primary. Primary is mainly due to the genetic defect or maybe due to some underlying neurological problem or chromosomal abnormalities. Secondary is mainly due to the acquired causes. And if you look at the acquired causes, around 60 to 70% of acquired autism is due to the early exposure to the digital gadgets or digital instruments. So 60 to 70% is due to the exposure to the digital instrument like the smartphone. So if we can prevent the early exposure of this smartphone or laptop or television, we can prevent 70% of autism. Secondary autism, okay? Primary autism is mainly due to the genetic defect, chromosomal abnormalities, or it may be due to some kind of underlying neurological problem. So if you look at the etiology, it is multifactorial in origin. It can be due to the genetic causes, neurobiological abnormalities, environmental factor, what I have already told, due to the early exposure to the digital gadgets, or it may be due to the deficiency of multivitamins, vitamin D, folic acid, zinc, or it may be due to prematurity, low birth weight, or some kind of perinatal asphyxia. There are many other etiologies are not defined. So, I mean, in some cases, there is no any genetic abnormality, any environmental factors, still the children are having autism spectrum disorder. So we can put them in other or unknown etiology. Now coming to the risk of recurrence, if there is one child, the risk of recurrence is around 4 to 20%. Okay. If it is a boy having this autism spectrum disorder, the risk of recurrence, if it is 4%, and if the child is girl, the risk of recurrence is double, means that will be 8%. Okay. So a boy, the risk is 4%. If it is 4%, the risk will be double if the girl, one child is the girl. If it is more than 2 children, then the risk of recurrence is around 30 to 36%. In case of monozygotic twin, the risk of recurrence is around 36 to 90%. we screen audit or diagnosis and intervention plays a very important role in the prognosis or outcome of this condition. We should screen children whenever they are coming to us for anything, for routine checkup, for the immunization, or for any health checkup. We should screen as early as possible. Okay. According to the American Academy of Pediatrics, at least we should screen them at 9 months, 18 months, and 24 months for the autism spectrum disorder. Now, coming to the medical evaluation, a good history plays a very important role in autism. So, what are the history? Family history of autism, as I have already told, that will identify, that will tell you about the risk factor. Consanguinity of marriage that will help you to understand about the neurometabolic disorders, because they are autosomal recessive in nature. So if there is a consanguinity of marriage and the child is having some kind of developmental and some neurological manifestation, then you can suspect neurometabolic disease, and you can screen for metabolic. You can go for metabolic screening by doing the TMS or GCMS. Then you ask for history of regression. If there is history of regression in all the field, means there is a motor delay, fine motor, gross motor, social, language, vision and hearing, that means it is a case of neurodegenerative disease. Many neurodegenerative disease, they can also autism disorder.
For connectivity, might be madam has left out. She is joining once again. Respected doctor, just wait for a few seconds. I'm connecting. Could be their network issue. Madam has left. I'm calling her. Madam, unmute करिए. Just one second.
Now you are able to see me?
Yeah. Now present it, ma'am, once again. Probably some network issue could be there. Make share your presentation.
Yes, but the screen is blocked by. Yeah, I have always shared it.
You just once again share it. It has not come.
The share screen is not
locked. Okay. 1 minute. Yeah. Now share it, ma'am. Can you share it?
Okay. It's
just hold on. 1 minute, madam. Fine. Make full screen. Perfect. Madam, you are muted, I think. Unmute yourself, ma'am.
yes. Now you are able to listen me?
Yeah, it's okay. Fine.
Okay.
Perfect.
So you ask for history of okay. You ask for the history of regression. If there is a global regression, that means you are dealing with a case of neurodegenerative disorder. If there is regression of the language and social, then this is a case of autism spectrum disorder. Then presence of risk factors like prematurity, low birth weight, increased paternal age, increased maternal age, we know associated with Down syndrome. It increase paternal age. Father says if it is increased, then they are associated. It is a risk factor for autism. Then on examination, you see examine for macrocephaly. Usually, the autistic children, they will have a macrocephaly in the first 2 years of life. Then gradually the circumference will decrease. If there is a clear microcephaly is present in the first 2 to 3 years of life, that means we are dealing with a neurological cases, so we can go for a neuroimaging. Dysmorphic features that indicates chromosomal abnormality or any kind of syndrome. And neurological sign, if there is a focal neurological sign or any abnormal neurological sign is present or any kind of neurocutaneous marker is present, then we can understand that we are dealing with a case of any neurological disorder. So we can go for neuroimaging and other neurological investigation. Along with that, developmental gain on follow-up is very important. So after diagnosing, it is not enough that we will diagnose the case, it is an autism spectrum disorder and send the child to the therapist further to continue the therapy. You have to explain them that it is it is not a disease, it is a disorder. You need a long-term therapy. If you will continue the therapy for a period of 6 months, 2 years, definitely you will get some result. So in between, you have to follow children every 2 to 3 months. What is the developmental gain? Okay, don't leave these children with the therapist only. You have to follow them every 2 to 3 months to know about the progress of the disease or progress of the condition. Now coming to some red flag signs. Red flag signs, you can see here, we usually judge the mind in the eyes of the people, okay? The eyes without telling anything can say many things. You can, by looking at the eyes, you can tell that whether he is happy, angry, frustrated, or he is depressed, okay? The most important features in autism is a poor eye contact. Poor eye contact with whom? Poor eye contact with a human being, okay? The person in front of him. So because of this poor eye contact, they will keep themselves busy in the object around them, okay? So what is the common object they are getting these days is a smartphone. So what the parents will come and tell you, ये तो पूरा पढ़ा है, मैं मोबाइल में YouTube खोल देगा, सब कुछ आपको दिखा देगा. That is due to the busy in the object, and it is a repetitive or restricted and repetitive pattern of behavior they have developed with the object, the mobile or the smartphone. So now coming to some red flag signs. The red flags: no vocalization by 6 months, no babbling by 12 months, no gesture by 12 months, no use of gesture by 12 months, no single word 16 months, no 2 words by 24 months or 36 months, and any kind of regression of language or social skill, we can suspect we are dealing with a case of autism spectrum disorder. So these are some other signs like inappropriate playing, inappropriate laughing, giggling. So there are many other symptoms. I will not go into the detail of the symptoms of autism spectrum disorder. And this slide shows one brain with overlapping syndrome, okay? If it is a secondary autism, that means if it is an acquired autism without any underlying neurological and is associated with any of this condition, if we can diagnose this type of autism, this secondary or acquired cause of autism is earliest below 2 years, and start intervention early, definitely the prognosis or outcome will be excellent. If it is a acquired or secondary autism, and not associated with any one of these, if we diagnose below 2 to 3 years and start intervention, definitely the prognosis or outcome will be. But when they are associated with epilepsy, anxiety, sleep disorder, ADSD, or learning disability, then it is difficult to manage children with autism. Now coming to the diagnosis, how to diagnose autism is obvious, and what are the challenges? Challenges are there is no any Bauman to confirm diagnose autism. Okay, like in malaria, we are getting the malarial parasite, we are confirming it is malaria. We are doing the Montes test, it is positive, we are telling it is tuberculosis. So there is no any biomarker available to confirm the diagnosis of autism. The signs of autism is subtle below 2 years. So we can predict that the child might be, this baby might be to develop autism, but we cannot say below 2 years that I cannot label it as autism. To wait till the age of 2 years, because the brain goes very rapidly in the first 2 years of life. Many things can change due to the neuroplasticity or due to the neuroconnectivity. Many things can change. So you wait till the age of 2 years to confirm your diagnosis that you are dealing with a case of autism. No screening tool is perfect predict autism, but all the screening tests, there is some defect is present in every screening tools. This is a new assessment scale by which we can predict autism as early as 3 months of life. Because of the awareness, we are now able to diagnose autism. Incidence is 1 in 59 because of the awareness. Okay. So now it is our responsibility to create the awareness for early diagnosis and intervention. Our idea should be the awareness, our focus should be early diagnosis and early intervention. Okay. The general movement assessment, this is a simple method. I will tell in the next slide, by which we can predict as early as 3 to 6 months of life. There are various screening tools are available like MCHART or MCHART, that is a modified checklist for autism in toddlers, or MCHART-R, ISA, that is Indian Scale for Autism Assessment, INCLIN tool for the autism diagnosis, Childhood Autism Rating Scale, PLADOS, ADIR, and SCQ, that is Social and Communication Questionnaires. So in chart, if the score is less than 3, that means very low risk to this moderate risk follow-up, and you can start the intervention. If the score is 8 or more, that means they need the diagnostic evaluation and they need the early intervention. If the score is coming between 3 to 7, don't wait to confirm your diagnosis. You can start the early intervention. You can start the intervention as early as possible to change the outcome or to get a good prognosis. Now coming to the general movement assessment, it is a simple method. After the feeding, after 10 to 20 minutes of feeding, when the baby is awake and sleeping on the bed, just you observe the baby. Ask the parent to record the movement, okay? Record the movement, general movement of the body, raw motor activity of the baby for a period of 5 to 10 minutes. Usually, the movement between 3 to 6 months, or let's say 3 to 9 months, the normal movement of the baby is called fugitive movement. Means it is very rapid movement. I cannot predict that baby will move the left hand, or after that the baby will move the right hand, or he will move the left leg or right. I cannot predict. Okay, this is called fugitive movement. So if the fugitive movement is present, that means the baby is absolutely normal. If the fugitive movement is absent, even at the age of 6 months, I can predict that they are particularly going to develop some kind of neurodevelopmental abnormality, including autism spectrum disorder. So what is that? If I can predict that the baby will move the left hand, after that he will move the right hand, then he will move the left leg, and he will move the right leg. If I can predict this type of movement, this is called general movement assessment. If I can predict this movement, I can understand that baby is going to develop some kind of stereotypic movement, and most probably the baby is going to develop some kind of neurodevelopmental abnormalities, including autism spectrum disorders. You can see this video, and so there is a typical, so they are able to understand the baby will the right leg. Okay, if I predict that, then I can understand that maybe is not having the fidgety movement, is absent, so is he or develop some kind of neurodevelopmental abnormality, including autism spectrum disorder. This is the movement is not fixed. I cannot predict whether he will move leg or he will together. Okay? If I predict the movement, that's normal, and the baby is going to develop some kind of neurodevelopment abnormalities, including autism spectrum disorder. Now, coming to investigation, what are the investigation we can do in autism? That is, we can go for a beta because they they usually come to us with a delayed language. If there is any kind of neurological abnormality, go for neuroimaging like CT scanning or MRI. CT is not necessary, you can go for an MRI. If MRI is not possible, then we can go for the CT scanning. If there is a clear dysmorphic feature is present, we can go for a chromosomal microarray. History of consanguinity of marriage is present, and we are thinking that the baby is having some kind of neurometabolic problem, then go for metabolic screening. All cases of delayed development, do the thyroid function test because thyroid is a hypothyroidism is a treatable condition. EEG, I will tell you what is the role of EEG. We can go for liver function test, CBC, and serum copper and ceruloplasmin. So genetic test available, or we can do in autism spectrum disorder. This is chromosomal microarray. I have told you, if there is a clear dysmorphic feature is present, we can go for a chromosomal microarray. If the family cannot go for the microarray, or you are suspecting, if it is a boy and you are suspecting from the dysmorphic feature, it is a fragile X syndrome, go for a fragile X PCR. Don't go for the chromosomal microarray because microarray may not pick this fragile X syndrome. So go for fragile X PCR. If it is a girl, go for the MECP2 mutation to find out any kind of Rett syndrome. And if there is no any clear dysmorphic features and it is not, you are not able to understand, go for a whole exome sequencing. Whole exome sequencing, this is whole exome sequencing trio. Trio means for the child and for both the parent. So these are the genetic study we can do in case of autism. Now, what are the indications of EEG? EEG is not recommended in all cases of autism. What are the indications you can do in case of if there is a progressive cognitive decline, if there is an atypical regression and you suspect syndrome or CSWS, if there is any abnormal neurological finding or neurological symptoms, then you can go for the EEG. If there is unexplained encephalopathy, we can do the EEG. Otherwise, routine EEG is not recommended in all cases of autism. And parents should be consulted in epilepsy. The incidence of epilepsy in autism is around 30%. So there are some newer methods to diagnose the autism, that is fractional MRI, quantitative EEG, eye tracking test, head circumference growth trajectory, oxidative biomarker like homocysteine level will be high, low vitamin D or zinc level, and increased mercury, lead, chromium, and manganese. These are new methods of diagnosing autism, but all has, it's not, still it is all of them are in the infantile stage. Now, coming to the treatment, as it is a, I will not speak on the treatment because my topic was only this investigation or challenges in the diagnosis of autism. So the treatment is, it is a social disorder or behavioral disorder or communication disorder. The treatment is applied behavior analysis and applied behavior therapy, psychodynamic therapy, sensory integration therapy, and medical management is required if the child is hyperactive, if there is a sleep issue, if there is an abnormal if there is any kind of seizure, then we need the medical management. Speech therapy, occupational therapy, physical therapy, and complementary or alternative medicines in the form of high dose vitamins and minerals we can try. The drugs which are commonly used for autism are risperidone. We can use methylphenidate. In some cases, if the child is very hyperactive or some features of ADHD is present, we can try atomoxetine, clonidine. And for the new melatonin, carnosine, omega-3 fatty acid in the form of this Biobliss is also having cognitive and calibrant D, so we can use in autism from there. And the recent mode of treatment is internal or oxytocin. So to conclude, what is should be the approach to a child with autism spectrum disorder? The diagnosis should be by DSM-V to try to understand the intelligence or developmental level of the child, associated comorbidity, and the child. Things to remember or take home message is autism is not easy, it is a disorder. It's not disability, it is a different ability. They are not less, they are different. Autism is not a tragedy, it is a tragedy. And our main focus should be what the child can do rather than the cannot do. Okay. So with this, I am concluding my presentation. So this is the famous quote of Albert Einstein: "Everybody is genius, but if you are a tree, it will live its whole life believing that it is stupid." So we have to focus on what the child do rather than what the child is not to do. Okay. Thank you very much. Thank you for your kind and patient hearing in spite of the over to Dr. Sambhavi.
Ma'am, it was an awesome presentation there.
Hello.
Yeah, ma'am, if you can stop sharing.
Yeah, but so much internet is I was
Yeah, Shashmita ma'am, if you can stop sharing.
I have stopped my sharing. No?
Yeah, right.
I have already stopped sharing.
Right.
Can I share screen now?
Yeah, fine. So Shambhavi ma'am, you can now start sharing. Is it okay? Yeah, fine. Make a full presentation, ma'am. Yeah, perfect, ma'am.
Yeah. So I'll start my presentation. So first of all, thank you to the Biobliss company, Mr. Satyanarayan and Mr. Nitya, for inviting me here today. We all are celebrating the Autism Awareness Month, and we have two very interesting topics today. So I'm grateful to Dr. Sasmita for taking up the whole spectrum of autism so well. It has made my job a little easier, but I'll be talking a little more specific about approach to autism in terms of enhancing the social emotional development. So as we know, man is a social animal. We all know, we've studied since a young age. And a lot of this social emotional behavior is being influenced by two factors. One is the genetic and the other is environment. But see the environment we are living in today. We are more into nuclear families. There is a lot of screen time for every member of the family, starting at a very, very young age. Even child who's younger than 1 year of age is on the screen, taking the meals. Family time opportunities are less. And of course, the social media is making us more unsocial. And somewhere we have also observed this huge surge in disorders affecting the social behaviors and mainly the autism spectrum disorders. And we also heard a bit about social communication disorders here. So coming to autism, we already know there are two core features, which are, one is the features which are including the impairment in social communication and interaction. And the core B are the restrictive repetitive patterns of behavior. So today in my presentation, I'm going to talk more about these core features related to social communication and interaction. So coming to a few basic terminologies which we use. So one of the words is communication and language and speech. Though we use very commonly when a child presents to us who's not speaking, but they are not interchangeable. So they have a very specific meaning. To start with communication, so communication in simple words means exchange of information between two people, which is meaningful. And this communication can be through gestures, through eye contact, we just listened, So suppose a person is entering in the room and I make an eye contact, I smile. So the person knows he or she is welcomed. And this communication can also be through language or the verbal means of communication, where we are following a certain rule or certain system of words or codes to communicate. So for example, I want to say I like apples. So that apple has a specific meaning. Apple I can't interchange with I like trees or I like mangoes. So it altogether will change the meaning of that sentence. So there are certain rules which we follow when we are communicating, and that set of rules is basically the language. So language can be broadly the receptive language. Suppose I tell the child, give me water, and the child gives me water. And the expressive language, the one which I'm speaking. So this expressive language is basically the speech. So there are three areas of describing a communication, language, and speech. And we just studied communication is exchange of information between two people, meaningful, non-verbal, verbal, and language is the set of rules or the defined code which we have to follow, which we really can't change at our own whims and fancies. And the spoken language part is the speech. Okay, so with this understanding, let us dwell a little more into the non-verbal communication. And how do we make this non-verbal communication? How a young child makes this non-verbal communication? So a lot of this non-verbal communication, which is happening without speaking, is happening through the eye contact, through the facial expressions of the child, through the joint attention, pointing, gestures of symbolic gestures like, doing this for food or doing this for water, or thumbs up, like social gestures like bye-bye or thumbs up to say a good job. And so basically, let me explain a few more in more detail. So this is an eye contact which is happening with a young baby and the mother, which is they are making and looking at each other, which is the mutual gaze which they are sharing. Then joint attention. A lot of children around 8 to 10 months of age, most of the children in normal development course should develop a joint attention. And by joint attention, in simple words, I mean a child and the caregiver is jointly attending an activity. So it could be a near object, like in this case, where the mother and child are looking at the object, and it between the child will also exchange the glance with the mother. Or it could be a distant object where the child is showing the mother that object and will look at the mother and then jointly attending that thing. So any joint attention is one of the most important aspects of developing a good social emotional behavior in a young child as young as 8 months of age. Coming to pointing, a lot of children around 12 to 15 months of age would start to point. And by pointing, I mean that mature index finger pointing. So a child, if he points with the full hand or does this kind of pointing, or the hand of the mother or pulls the dupatta of the mother, that is an immature pointing. So we have to look for a mature pointing, which is a mature gesture, which a child should start doing by 12 to 15 months of age. So I just want you to have a look at this video and see the kind of non-verbal communication this child is making. So I would just request no one to please record the video. These are all personal patients and special permission has been taken. So kindly please just look at the video and see. So the mother is trying to show some object, but the child is not looking at the mother and is not having any exchange of the glance with the father who's sitting just right opposite. The child is totally ignoring the presence of the caregiver and doing some kind of movements here repetitively. So now coming to a little more detail about how this social emotional development takes place. So first we have to understand what is atypical, and then based on that we plan the interventions to reach the normal or typical. But I think more importantly, first we will now are going to go from the normal development to atypical so that we can do this aspect well. So coming to back to basics in terms of what are the social emotional development stages of a child. So when a baby is born at just birth, The baby doesn't understand the presence, this is the father, this is the mother. So how does the child perceive the environment? The child perceives the environment through senses, and the child looks at the face of the mother. Child may hear the sound of the mother, sound of the heartbeat of the mother when held close, may smell the breast milk. And this is how the child starts to perceive the environment around. And what happens when this child starts to perceive, the child also develops some emotional responses to this kind of perception. So the child may be happy to see the face of the mother, the child may be happy to see the sound, to hear the sound of the mother, and may also cry and be unhappy and show some fear. So three basic emotions which are present in a very young baby. And gradually, with age, the child is able to discriminate that this stimulus, the presence of face of the mother, makes me happy. And then this is where the child would start to give a social smile to the caregiver. Now, coming further on, between 2 to 5 months months of age, the child will start developing these social preferences. He will now express emotions more through verbalizations, like he may coo, make a cooing sound. He starts to read the facial expressions and recognize a pattern. And the pattern is like when I'm smiling, the mother is smiling. And I smile more, the mother smiles more. So there is a pattern which the child starts to identify, and this is when the engagement or relation with the caregiver is started to establish. And this is the stage of engagement or relation with the caregiver and proper recognition of the caregiver. Now, coming further on, during this, at the level of 6 to 9 months, this emotional reciprocity or the signaling back and forth is continuous, more chaining happens, and the child becomes more purposeful in initiating these communication. And this is by the end of 9 months where the child starts to have joint attention, where clearly the child now knows that if I am enjoying the rattle, which is my mother is showing or my father is showing, I am happy to look at the rattle, but I also understand this rattle is being provided by my caregiver. And they will jointly attend to that activity of showing the rattle, where the child would look at the rattle and would look at the mother and smile. So this is basically the joint attention stage. Now, as the child is increasing the age, now from 9 to 18 months of age, this two-way communication, the child is now also using its cognition, and starts to use this two-way communication to solve the problems. And the child is still not speaking, but the child would start to point. If he wants to go out, he would say, mm-mm. He wants something, he would say, hmm. So this is the proto-imperative pointing, where the child is going to express his or her needs through the pointing. The child may be very happy to see something. He sees the aeroplane on the sky and he's very happy and he wants to show, and he may show this to the parent. This is the proto-declarative pointing, which is to share the joy. So these starts to come around 9 to 18 months of age. And also the child will regulate the mood and then the behavior, which is dependent on the mood. And basically the child starts to understand a social, emotional, behavioral pattern. The child will understand when I'm crying, the mother is going to come and lift me and show me that, give me this candy or take me out. And this kind of pattern recognition happens, which is again a stage which is very, a lot of children with autism would not have this kind of social emotional development. Now, further coming on, the child at this stage starts to use symbols or words to communicate his or her ideas meaningfully. More imaginative play starts to develop. And further on, by 2.5 to 5 years, stage of logical thinking develops, interlinking of ideas, concept of where, why, ideas across the space. Even if the father is not present there, the child knows when the mother says the papa is in the office. And group play. So basically these stages which I just kind of elaborated on were by the Greenspan, and these are the 6 stages of social emotional development. So going through these stages, we also understand the development is not piecemeal. Lot of these developmental domains are interlinked. So when the child is learning to do social emotional thing, communication is automatically happening. And once this social emotional communication integrate, the cognition develops and a lot of problem solving skills start to appear. But we may also note, like lot of this communication in the first 18 months of life is non-verbal. So the child will develop communication, but lot of it is non-verbal. And again, when we come to autism, it is first 18 months of age where the child has not learned to develop a good non-verbal communication, the child will not learn to develop good verbal communication and thereby speech or language. So we talk about language milestones, we talk about motor milestones. Now, age-appropriate social milestones are also very important, which are 2 months. By age of 2 months, the child should have social smile. By 5 months, they should start recognizing the caregiver by sight. By 6 to 10 months, communicates back and forth. By 9 months, joint attention. By 12 months, can play peekaboo or wave bye-bye. 12 to 15 months, pointing to indicate needs, which is proto-imperative. By 16 to 18 months, points to share interest, which is proto-declarative. By 18 to 24 months, starts to do a lot of pretend play, feeding doll, talking on phone, and parallel play. So important social milestones we have to keep in mind when we are seeing a young child who is less than 2 years of age. So basically, when we talk about autism, all these atypicalities we start to see. There is lack of sustained attention. There is intermittent or no engagement. There is very few or no interaction, little initiative taken by the child. The child may respond to certain things like if the father or mother are saying ki chalo bahar jana hai, shoes le aao, child may get the shoe because it is a selective interest which the child would want to do and not initiate or sustain consecutive social interactions. And of course, when the speech starts to come, the child may show a delay or may use echolalia or do a lot of repetition of words and do perform in terms of patterns or memorized scripts. So now this part of my presentation would touch upon the intervention planning for these children with autism, keeping in mind the social emotional development approach. So when we plan intervention for any child with autism, we have to see the current level of functioning across all domains. The goal of the plan should be very, very clearly defined. And I think a pediatrician is the right person to define that goal because he is going to look at the holistic development of that child. I mentioned working on one aspect. If a child with autism is coming and we start just working on the speech, it is not going to help. The child has to start work on the communication, child has to start work on the social emotional skills and then speech. Caregiver involvement is must when we are planning interventions for children with autism because a child may come for interventions 1 or 2 hours or 3 hours in a day, but rest of the 21 hours the child is going to spend at home. And unless we are educating the caregivers, we are not really helping the child. Follow up, like Dr. Sashmita just mentioned, just sending or referring the child for therapies is just not enough. As a pediatrician, we can definitely follow up how the development of that child is progressing after the interventions. So we may not have very good knowledge about the interventions, but we can actually measure the efficacy or the effect of interventions through the developmental levels which are dynamic and which should be keep changing for the child. So a follow-up every 2 to 3 monthly is very, very important. In fact, we had published a study where we had seen 20 children of autism from the age of 24 to 42 months. And when we evaluated their social emotional development, all the social emotional development was coming less than 10 months of age. So though the children's chronological age varied from 2 to 3.5 years, but the social emotional age was even less than 1 year. So this is just to focus how important is to a social emotional development, and we have to have goals which are kind of affecting that aspect. So one of the most earliest goals which we keep is when we are working on the social emotional aspect is the attention. And by saying attention, I mean looking at the face or facial referencing, which means glancing to the face to share a positive moment or information. And the child may not look into the eye. So we don't have to force the child to look in the eye, but the child should just look at the face of the caregiver. And this we can do by not demanding or physically prompting. So we don't have to put the face of the child and say, ki meri aankh mein dekho and look at me. No, there is no physical prompt there. Caregiver has to become the center of attention so that the child starts to taking interest in the caregiver and start looking at the caregiver. There should be minimal use of objects because the moment we bring in more objects, the child is going to get distracted. The child is going to lose the focus from the caregiver to the object of interest. And of course, the caregiver has to be childlike, more animated, more expressive when we are working with the child. Less instruction. Don't give too many instruction while working with the child on these goals. कि इधर करो, ये करो, do this, do that. No, it's more of, this is more, should be a joyous experience, and the child starts to engage on his own. The caregiver should be at the eye level in close proximity to the child. And gradually, once the child may give a very brief millisecond kind of eye contact, but gradually with our efforts, we have to make it more sustained. So here I'm going to show a video of a child whom we started with attention or facial attention, and some objects or toys like balloons and bubbles can be used where the child, so just to drive that attention of that child to our face. So here the therapist who's working with the child is trying to be more animated, making few fun sounds, and making a balloon, keeping the balloon at a very level where it is between the child and the therapist, so that the child would look at the face. So similarly, when the child starts to give a little more sustained contact, we can also use some more methodologies where we are giving very slow counts, or we pause in between so that the child again starts to look at us. So, which you can see in this video. So you saw how the therapist is working with the child and giving some slow counts, and suddenly 1, 2, 3, and she pauses. The child will wait the next step to come, and the child will immediately give the eye contact. 1, 2, and 3. So once I mentioned initial attention the child starts to give, we can make the session more to and fro, making the child to have a better regulation with the caregiver, more engagement, more sustained engagement. And the role of child gets defined in the activity. The child starts to wait for the turn and limited instructions, because most of this work is happening. The child is working out of his or her own interest and motivation. So I'll just show a child who has a communication deficit is now paired or coupled to play with a child who's very good socially, but may have some other areas of concern, and how they are playing together. So this is the basically simple turn-taking activities and to and fro, making the child sit together close to two children where they are looking at the eye contact, looking at each other, and having some joyous moments together. So similarly, these are a few very basic tips which we just shared with you. And for a child who has attained a little more level of social emotional development, more activities can be given to coordinate as a single synchronized unit. And so for example, the parent start to involve the child in day-to-day activities like filling the bottles and helping the parent to put in the fridge, or some play, combined or cooperative play like building houses out of cushions and all. And further on, role plays can be taken. And further on, child when has a better social emotional development can start going to group plays where they are joining other children who have shared interest. And in fact, for adolescents, there are certain programs like peers program, which is program for evaluation and social functioning for high functioning teens with autism, which are a well-researched documented program which can be. So in all, my approach to autism, I would say really emphasize social emotional skills are imperative to a good, meaningful use of language and a regulated social behavior. So we may develop speech in a child of autism. The child may be repetitive if he doesn't have a good social emotional development. He may do it more like a echolalia, or starts, maybe counting ABCD or counting 1, 2, 3, 4, but really not using it in a generalized way. And also that such a child who has a poor social emotional foundation would be very unregulated. It would be very difficult for a parent to manage the behavior in a new setting or in a social setting. So I think these foundation skills, if we are worked upon, the language if the child develops or the behavior the child develops is going to be more regulated and more meaningful. So I would just end my presentation by saying be a child to coach your child. So when we talk about social emotional skills, it is very important, like we become childlike, we become at the level of child and start playing with our child. Thank you.
Thank you, madam. Shashmita, madam, are you on? Yeah,
Yes.
madam. Yeah. Thank you, ma'am. It was a very power-packed presentation for both of you. If you are having any questions are there, you can put it there in the chat box, or you can directly unmute and ask. Any questions on today's session? Any queries?
So I have asked the question that whether it is a mimicking condition, which mimicking condition you have to specify your answer. Well, yes, everybody has answered it is autism mimic, but you have to specify that mimicking condition, whether it is a social communication disorder, whether it is hearing impairment, what is that condition? You have answered it is autism mimic.
I think a response is there in chat box, ma'am. You can follow the chat.
So I have seen the response.
One question has come. I think, ma'am, are you following the chat box?
Yeah, I can see the question, and I think Pratyaksha has asked, till what age can ASD continue? That's what you're referring to? Yeah. So, yeah, Pratyaksha. So autism spectrum, when we say it is a disorder, which is basically a disorder which is lifelong, and it is not a disease which we give the medicine and can be cured. But it, having said that, I would also like to add it can be managed very well, where the child who is, and we all, when we talk about autism, we don't talk about curing autism, we talk about managing autism, so that the functional level of the child is maintained and is given to the child in terms of his independent functioning, functioning in the society, functioning at educational level, at all levels which are desired by the family. So it will depend on the severity of the problem, and there are a few prognostic factors which we have to keep in mind while assessing the children with autism, because many of the milder cases who would be fulfilling the autism criteria at certain age may, with interventions and proper care, would benefit so much that they may outgrow the criteria for autism which they had started initially with. So I think the more focus has to give in restoring the functionality of the child, and there may be a few minor deficits which may be left, and we may present even in milder cases till the adulthood. But that's okay. We all have our own quirks and all, I think, and so do children with autism, because we have to accept autism is not like something which is totally disastrously wrong and has to be corrected. We have to start accepting autism people as their own people who have their own individuality, and basically they have a different way of thinking, different way of expressing, but not like something which is totally a disease condition kind of thing.
I think Shashmita ma'am, for time being, because of network issues, she is bit out. She is also once again trying. And any more questions are there? You can put it. We'll wait just a couple of minutes. Ma'am has confirmed me that she is joining.
Yeah, so another question is there. Deepthi has asked, can we pick up autism prenatally? So there has been a lot of research, and ma'am also mentioned about the whole exome sequencing and all. So in children who have autism and the family wants to go for genetic counseling, we do offer array of genetic testing, but there is no one single test which can determine ki this test is there and we know this test is positive and autism can be confirmed. So a lot of genetic counseling has to go keeping what are the current clinical features of the child who has a problem. And if there is a problem, if there is a mutation detected, whether the mother or father are the carriers. And then when the mother gets in the antenatal period also screened for the same mutation. So it has to be a proper genetic counseling and approach. But if you talk about one test which can be confirmatory, there is no one test. We right now the exome sequencing test is being offered more of from a genetic counseling point of view. So Dr. Sasmita would like to add something to that.
Poor connectivity. I could not listen the question. What is the question?
So can autism be picked antenatally? I think ma'am has still lost the connectivity probably.
Put off your video, the connectivity would be a bit better. Once again lost. Okay, so respected doctors, we have to close, I think, end of the session. So once again, it was an awesome presentation was there from both the eminent doctors, and Biobliss expressed their gratitude despite of their very, very busy schedule. You have spared your times, and all these doctors who has viewed this program. We are very thankful to all of you. So we are calling it a day. But yes, this is the autism month. We will be meeting again and again, maybe every week. We'll be meeting and obviously interacting with you all. Thank you. Thank you all. Good night.
Thank you everyone. Thank you.